Content of my talk will be on the classification of transfer of ECMO, the indication, the requirements, the team and equipments, mode of transfer, checklist, risk factors, outcomes, and I'll share our experience with examples and the summary. So this is an example of an ECMO patient. You can see a lot of gadgets around the ventilator, the ECMO assets, the monitoring machine of the ECMO, and the syringe pumps. A lot of things are there. It needs a larger space than the patient who are normally managed without an ECMO in an ICU itself. So we have to shrink this space to a space like this inside the ambulance, where it is very narrow and can be longer. That's all. So this is the challenge we are going to face here. Generally, the transfer ECMO are broadly classified into primary and secondary. Primary means the team which goes for transfer ECMO, initiates the ECMO, and also transfers the ECMO. There is a time constraint here because these patients are referred often very late, and time of calling the team to the time when the team reaches the hospital matters a lot, because still during that time the patient may deteriorate and may not be a suitable candidate for transfer. Once the team lands there, they reassess the patient and see the actual situation, whether it can be transferred with the ECMO or not, and take a decision on that. And these type of patients are more challenging because once you initiate a patient, as you all know, there may be some hemodynamic instability can be there, can be an episode of SIRS or bleeding issues like that. So once we settle everything, then we can transfer these patients. The second group of patients is a secondary transfer, which those patients are already on ECMO, stabilized, and only transferred from one center to the other center. This can be done in a very controlled manner, and time is not a great constraint here. So let us see the indication, why a patient needs to be transferred. Obviously, when the center in which the patient is managed doesn't have an ECMO facility, but the patient needs an ECMO, that patient have to be considered transfer. And the next group of patients are, we initiate the ECMO, but the patient, unfortunately, the organs under consideration, either the heart or the lung are not recovering, and they have an irreversible organ damage, so have to be moved to a transplant center. So these kind of patients needs to be transferred. And those candidates who are a candidate for heart and lung transplant patients, but they can't be shifted out of the ICU or transferred to the transplant center without the ECMO. Some of the patient what we receive, like lung transplantation, all they will be on ventilator with FA out of somewhere around 80%. Those people can't be transferred safely. Rather than we can place an ECMO and then transferring them are much more, it will happen in a controlled environment than transferring these patients without ECMO. So next group of patients are initiate the ECMO in an emergency situation, but the team doesn't have enough experience to manage this patient in a prolonged manner. So these kind of patients also needs to be transferred. The requirement can be broadly classified as ECMO team and the equipments needed for transfer. ECMO team as such, each and every center have to have their own protocols. Our team consists of perfusionists. They are very important for transfer. And next is the anaesthetist, then the cardiothoracic surgeon, and the technicians. These people are mandatory. And when the patients go for primary transfer, that is initiation and the transfer, then we get our theatre nurses also along with us, the coordinators, and as you saw in the morning, the intervention radiologist and also the vascular surgeon, depending on the situation. If the patient is going to be on very high inotropic supports, for example, like Dr. Vignesh said, something like 80 or 100 ml of noradrenaline, there will be intense vasospasm, and even attempting on a percutaneous technique, we will not be able to cannulate. Those kind of patients have to be opened and then try it, rather than poking it and then injuring and then trying it, leading to bleeding complication later. We believe in multidisciplinary group of team approach. So we don't hesitate to call for help. So vascular surgeons are always better in handling the vessels and exposing and giving to us rather than we attempting it. And next is the equipments. So this is the ECMO kit, what you are seeing. That ECMO kit contains pretty much everything. Our perfusionist, Mr. Emmanuel, organized these things. Those contains ECMO circuit, cannulas, sometimes surgical equipments also will be there, like instruments, other things, in case you need a open technique, including the peripheral or the central. Those things will all be there. So also the ACT machine for long distance travel. manual or power backup ECMO machine should be there. For example, like if is there any issue with the power supply, then there should be a provision for hand cranking, or else there should be another backup machine like how you have for Centrimac machine. You have another machine that can be connected immediately. Also suction apparatus where you need repeated endotracheal suctioning and all, reliable oxygen source, and also the monitors. Of course, if there's going to be a long distance travel and the patient is going to need a lot of blood and blood products during the transfer, especially during the primary transfer, then blood and its products also are mandatory. And necessary medications, maybe like twice the amount generally planned to manage have to be there, and also emergency medications. Also the team should have some idea about the way in which they are going in case of emergency, or else in case of any untoward incident, where to get the help also they should know. And the mode of transfer can be broadly classified into ground ambulance and also air transfer. Ground ambulance services can be obtained within, say, if the transfer is going to happen within 400 kilometers, or else air transfer you can broadly classify it as helicopter transfer and fixed wing aircrafts. Fixed wing aircrafts are, can be used for very long distance travels. Ground ambulance transfers, first important thing is power supply. We need power to run the ECMO. ECMO does have a backup power of around 1.5 hours or so, but you can't rely on that. So better to have a stable power supply from the ambulance. So around 230 watt power supply should be there. Medical gases facility should be available. Always have a reserve of at least twice the amount of the distance planned, or else in between wherever you are traveling should be there an hospital to provide you some cylinders, or gas filling station should be there in between. And the patient should be accessed at least from 3 sides. So one side will be always close to the ambulance. Other 3 sides the patient should be accessed in case of emergency. So the equipments, the stretcher or the railings and other things should be of the dimension so that the equipments can be attached to it, and during the transfer they will not slip out. Also, the one should have adequate restraint for the patients so that the patient will not fall during the transfer. Air ambulance, I think all the other mentioned I should have, and much more apart from what I mentioned should also be there. The challenges what we face during the air transfer are there will be a significant difference in the barometric pressure changes. So any air collection inside the body, like for example pneumothorax, it will enlarge in size. So one should be equipped with say ICD for insertion. Simple ET cuff also may get distended. That's what is expected. Also, there will be a significant temperature variation, especially in fixed wing aircraft, where it goes in a much higher state, where there may be a hypothermia. So these kind of ECMO machine, sometimes it is better to carry the warmer also. If the weight doesn't permit, at least cover the tubings and other things with the silver foil so that there will not be much heat loss till you get it to your center. And the reduced air humidity, noise, vibration, everything matters, and this can tire the entire team. Also the weather challenges. When we go by road, we often see the roads how it is, and it is easy for transfer, or else it is hazardous for transferring. Wind, of course, here. The snowfall till now is not a very big problem in India, but abroad it is a very great problem. Always leave the choice to the pilot's decision. In material of what is the patient's condition, pilots makes a decision whether to take off or stand down, and, depending on the weather condition. Coming to the risk factor of these patients, there are 3 important risk factors for these patients. Like one is the SOFA scoring. Higher the SOFA scoring, the lesser the chance of patient survival, and also more the chance of adverse events happening during the transfer. Lactate more than 10, better to have the patient in the center in which it is getting managed itself, get the lactate down, have a control, and then shift, rather than hurriedly shifting these patients, which can mount to many complications. MAP less than 70 is also one of the complications which can anticipate with somewhat a lower dose of inotropes. Generally, the mortality rate of these patients of transfer is anywhere between 0 to 0.15%. Adverse event chances are around say 20 to 40% depending on the center, and this can be due to multiple factors. It can be due to a pump failure, ECMO pump failure, where maybe pump failure due to the pump in per se failure, or else due to the electricity lag. In that case, we need to change the pump, and then or else if there is an electricity failure, you have to hand crank. An infusion pump failure, always have some infusion pumps as a standby, or also the team should be geared up to calculate the dose and run it in the bag, saline bag itself, instead of depending on the infusion pump, or oxygen depletion can happen. When this happens, it's a nightmare to any transfer unit. At the time, place the patient on minimal oxygen requirement so that the saturation is around 75 to 80%, and then to prolong the journey rather than hurriedly having a 94 saturation and then you end up without any oxygen in the later part of the journey. And there may be a lot of electrolyte, this one electrotherapy can be a requirement for these patients, because there may be some hypothermia, and also during the transfer the fluctuation in the electrolytes can happen. So these patients may need a pacing or a DC shock during the procedure. Cardiac tamponade can happen, especially when it is done by an open technique and also a primary transfer. Migration cannula, kinking of the cannula, all are possible. So our unit has a uniform policy that all the ECMO cannula from the insertion side to the machine, from the machine to the patient, all the tubing should be exposed and to be seen by the all others. If it goes hiding behind some say bedsheet or any other equipments, then it can get compressed or kinked. So our unit policy is keep the tubings and the cannula exposed from the patient to the machine and machine to the patient. A pneumothorax can happen, and for which we may need a ICD. And hypotension hypoxia may happen in this patient due to the partial pressure changes. Bleeding, of course, can happen in the pulmonary, GI, or intracranial during the transfer. And clotting of ECMO circuit is also possible. So only you should have a spare ECMO circuit in your kit so that we can change it. Lower limb ischemia is another possibility. So if it going to happen during the transfer, then maintain with some heparin, localized heparin injection through the peripheral distal cannula or flushing, things like that, till you reach a specialized hospital. Warn the specialist hospital that this patient is going to have a lower limb ischemia so that they can directly get into the theater and sort it out. Always, like as you said, as we discussed, you can see like quite a lot of complicated things are going on. So it's a highly demanding and stressful circumstances can significantly affect your situation awareness. So your brain can function normally if it is cool and calm, but ECMO transfer is not at all like that. It is a highly demanding and stressful condition. So one should have a checklist. If you don't have a checklist, you may like miss something. In air, you can't find that whatever things is there. Even a small connector, which is very crucial to save the patient, you may not find it in the air, which is very easily available in the ground. So checklist is very mandatory. And checklists can be categorized into three things, like checklist for the patients, checklist for equipments, and checklist for logistics. Timings. This is to improve the efficiency of the team without compromising the safety. The response time from when the patient when the team get the call to the when it is going to go to the field and then initiate the ECMO. That is the first thing is a response time, and next one is the flight time, from where the flight take off and to the landing time, and the handover time, how the referral team hands over to the the team who is receiving the patient, and the total mission time. So this and all to be kept in the minimum without compromising the patient safety. So coming to our experience, we have done close to around 278 ECMOs. Out of that, 52 were transfer ECMOs. V-ECMO were 9 and VV-ECMO were 43. The ground transfer was around 23 and the air transfer was for 29. The international ones, mostly from the Middle East, were 4. First, we started with the intra-hospital transfer. This helped us a lot to gain experience in transferring the patient from one part to the other. So we transferred the patient to the CT scan, to the operation theater, for the complex endoscopic procedures, to the cath lab, those things. Like this is a patient who got transferred to the CT scanner. So when we transfer the patient, it is a little different from the transferring the patient from one hospital to the other hospital, because these patients are going to lie in the bed where that is going to get managed. It's a little bit easier, but it is also riskier. So we have going to place the ECMO machine, other things in the bed, and we are transferring this patient to the CT scan. That patient is undergoing a CT scan here. That's how we position the ECMO machine in the CT scanner and then take a CT scan of these patients. All the machine and other things come to the foot end of the patient. And this is one of our patients who had a ECPR and the post-ECPR situation, post-CABG. Chest was packed, and we know arterial ECMO. We got it to the theater for LV decompression. We decompressed it and shifting back to the ICU. This kind of patients and all, central cannulation, especially the fixation of the cannula and other things are very important. Otherwise, cannula migration can happen, which can be life-threatening. And transport monitors, like the one what our anaesthetist Dr. Ganapathy is having, it's a very small and sleek one, which shows the heart rate, blood pressure, and the saturation. These are things to be monitored on these patients. And when we transfer these patients, the doorways can be very narrow, in which we need to get them up. So it should be a proper planning should be there. This patient had a ECMO and also an IVP machine, and the team should coordinate with each other so that the patient moves through the narrow airway also, narrow doorway also smoothly. Coming to the ground transfer. So first, while transferring the patient from one hospital to the other, transfer the patient to the stretcher. The stretcher should have some, say, railings and other things where these equipments should be fixed. So this is what is happening here. And after proper fixation and securing the patient, you can see the straps and other things were secured properly, the monitor, and it has been on go. And sometimes your hospital in which the patient is retrieved may not have a proper lift. So these kind of patients have to be moved through the staircase. So we moved a patient like that through the staircase during the COVID times, tough times. So this is how it has been transferred, a patient on ECMO, and that patient went home well. And ECMO transport can be done in rotaflow also. So also the cardiac health, which is very sleek machine through which this patient can be transferred. And inside the ambulance is a space what we have, like this only we position the patient. And sometimes we request the government, they are kind enough to provide a green corridor so that the shifting can happen quickly. At transfers, we work with the ICAT team. They are the experienced team in the international transfer of these patients and all. Dr. Shali and Dr. Rahul are specialized in international air transfer. So we work with them and then we transfer these patients very safely. This ICAT team transferring into the flight. We have done 4 international transfers. And when both machines are simultaneously together, like both are same machine, only this pump head or else the oxygenator alone can be changed. This should be done quickly. This is a ready machine to receive, and this is to be deployed. This oxygenator will be transferred to here, and then this machine will be taken over by the team which sent the patient. Outcomes, our mortality during the transfer are nil. Adverse reaction is around 7.7%, 4 out of 52. One was a pump failure where we had a backup pump and we connected it. Another is an electrical failure where the person hand cranked for say really 1.5 hours, interns and got the patient. Next patient had a significant pulmonary hemorrhage where the heparin was stopped and then managed here. By getting here, we gave the Zamic and then treated. Another patient had a significant arrhythmia and hypertension. So this patient actually moved from Ahmedabad, landed in Mumbai, and then stabilized the arrhythmia for 2 days, and then we transferred back here. So future of this transfer ECMO, a dedicated ECMO ambulance is mandatory to manage these kind of sick patients. Train ambulance is one of the choice through which the ECMO patients can be transferred without much jerks and hazardous roads. So more simulation courses are needed. Miniature ECMO machines may ease our transport things. In summary, it's a complex and demanding and stressful process of the transfer of ECMO. Well-trained, cooperating and dedicated ECMO team is needed. Clear communication should be there between the team members, and checklist is mandatory. Thank you from our team.
Thank you, Dr. Madhan, for excellent presentation. Just a couple of questions. Do you take a separate consent for the transport ECMO during the transfer? And second, the cost of transfer.
Okay, first is a very good question. The transfer ECMO, like the ICAT team, to transfer from through the air ambulance, they have a separate consent form for transferring from the patient from here to there, including the risk to life and unpredictabilities, everything they will mention, and then get the transfer. For the ground transfer, we usually tell the patient and document in the case sheet, but we don't take generally the separate consent form for ground transfer.
Okay. Thank you.